Okay, perfect. So, dear colleague, good afternoon. My name is Daniela Gompelmann. Me and my co-chair Rocco Trisolini from Italy want to welcome you to a late session. This session is about Roseborough's pitfalls, artificial intelligence, and modern cytopathology. I think this is a very interesting session, and we have got 3 different talks by excellent speakers. I don't want to waste time because we are already a little bit late, so I want to introduce our first speaker. This is Philip Emmanouil. He will talk about the TBNA rose.
So thank you very much for the invitation. It's truly an honor. So in the next few minutes, I will try to motivate you to use rapid on-site evaluation in your bronchoscopy suites. It's a very gratifying method for the bronchoscopist as well as the patient. The results for the patients are much better when we use ROSE because when we do TBNA in general and EBUS TBNA in particular, our samples with the needle can have various pictures. They can be mostly from the bronchial mucosa, so there will be prevalence of bronchial cells. We can have a good sample and have malignant cells, or we can have the last picture on the right, which is a prevalence of necrosis. So when we have bronchial cells and when we have necrosis, it's not very much useful, so we have a procedure that unfortunately went to waste and it was not good for our patient. So what is rapid on-site evaluation? It is a technique that is based on the presence of the cytopathologist in the room. We use a specific dye. It consists of 3 solutions. Solution A, which is a fixative for the cells, solution B for staining the cytoplasm, and solution C for staining the nucleus. So it's a very quick procedure. You can have a slide ready in 30 seconds, and then you can have the cytopathologist who sits next to the bronchoscopist and assess whether the material is adequate for diagnosis. This is a technique. Usually when we use this technique, we have to separate between histology and cytology material. We set the histology aside in formalin for the cytopathologist to examine later, and then we do the sequential staining and rinsing of the sample, and we have a microscope next to us, and we observe the sample, the slide, with 2 magnifications, a broad magnification of 10 to see exactly where we have islets of cells, as you can see in the picture down left, and then a 40 magnification in order to assess really the morphology of the nuclei. So what we aim with ROSE, we aim to assess sample adequacy. This is the most important issue. There were some, in the past, some scientific questions about whether we can prematurely stop aspirations, do less than 5 when we do TBNA, when the sample was adequate, so we can reduce adverse events such as bleeding. This is not a matter at this moment because even if we have sample adequacy, we need a lot of samples in order to do as well the molecular testing or the immunological testing. We can also use ROSE if we use a certain modality. If we do TBNA and we don't have a sample material, we can switch to EBUS TBNA now. At the moment with systematic lymph node assessment, this is not also very contemporary. So when we aim to do ROSE, we have to be able to identify some form of cells. So when we puncture lymph nodes, we should know how the lymphocytes look like. So they are large with a dark staining nucleus. There is no or little cytoplasm, and usually we have this picture, as you see on the right, of scattered lymphocytes when we dye and we observe the slide at a magnification of 40. Sometimes it can be a little bit more complicated. If we have pieces of lymphoid tissue, it can look like this, and it can complicate us and wonder if we have lymphocytes or we have malignant tissue. What we should also be able to recognize is the bronchial epithelium. If we see such a cell with cilia, we know that it is a bronchial cell, and usually these bronchial cells in our samples will be arranged like this, nicely with the cilia on one corner, with a terminal bar. Now, in the case of malignant tissue, when we do rows, we usually see non-small cell lung cancer or small cell lung cancer. When we have non-small cell lung cancer samples, usually we have this irregular nuclei which have various sizes and an abundance of nucleoli inside. So we observe this multiple nucleoli, we see that there is irregularity in the size of the nuclei, so we know that this sample is adequate and it's malignant. There are some specific forms that can be infrequently seen, such as these keratin pearls we can see in the squamous cell carcinomas, or some tadpole cells, which are also common in squamous carcinoma, but the important thing is to see that the material is adequate. We do not aim for a diagnosis. In the case of small cell lung cancer, we see quite a little different picture. The cell size is medium size. They're a little bit, the cells are a little bit bigger than the lymphocytes, and they are cuboidal in shape because due to the large number of proliferation of the small cell lung cancer, the cells are packed in the lymph nodes, so they're disformed and they are cuboidal. And also when we stain it, they tend to be friable, so they're broken, and this chromatin striations are present. This is produced by the smearing of the slide. So in the beginning, there were quite some number of non-randomized clinical studies. This is the pivotal study by Davenport that showed that if we use rows, we have a significant increase of samples with malignant cells present. So we can increase our sensitivity. The study by Dieter that followed, which included malignant and non-malignant material, also showed that the diagnostic yield improved by 64% when rows was performed. But then we had a series of randomized trials and which really assessed the diagnostic accuracy of TBNA with and without rows, and it was shown by this study for Professor Trisolini that actually the diagnostic yield was the same in both groups. So is that the end of rows? No, the same study showed that if there were multiple targets like lymph nodes and a lesion suitable for transbronchial biopsy, if we used rows, we were able, and more confident with our material, and we were able to avoid biopsies or other diagnostic procedures in the same patient. So complications were reduced in the rows group. A second randomized trial by the group of Yarmus and showed exactly the same results. The diagnostic accuracy was similar in both groups when we were using or not using rows. Also, transbronchial biopsies were reduced in the group of rows. So that's where we are at the moment. We know that with TBNA, and rows, we cannot increase our diagnostic yield, but we can avoid transbronchial biopsies. What about EBUS TBNA studies? 2 studies, similar results, less transbronchial biopsies when rows was used, and in Acquire registry, which was a large registry of bronchoscopies from the United States, it was shown that when we used rows, transbronchial biopsies were performed in 6.4%. When we were not using rows, transbronchial biopsies were in 14% of bronchoscopies. So to summarize, using all our existing technology, we cannot manage to increase the sensitivity of TBNA with rows. Nevertheless, we can assess for sample adequacy and we avoid further paracentesis or transbronchial biopsies. It is true, though, that rows is underutilized because we simply don't have cytopathologists in our lab. It is an extra cost, and usually they don't make the time to come to the bronchoscopy suite. So if we cannot have him in the lab, can we at least send him the images for evaluation real time? Or can we train the bronchoscopist to assess TBNA smears with DiffQuick adequately? What can we do with the gene polymorphism and immunology that is needed in standard oncology care at the moment. And can we replace everything with artificial intelligence, forget about the human factor at all? So the first question is whether we can transmit our images to the lab. This has been solved. It's called Telecycle Pathology. We have a lab. It is connected to the internet. We can transmit our images to the cytopathologist. He can give us a result about whether we have adequate material or not. This has been also standardized at the moment. There is also a robotic telecytopathology. You can see here a nice machine from Sakura Vision Tech, which actually is an integrated microscope, and you put the slides inside. It has a robotic microscope, and you can transmit the images. Can a pulmonologist, a bronchoscopist do ROSE? This is a pivotal study from the group of Professor Gasparini. A lot of cases. After a standardized curriculum, the pulmonologist assessed material and training, of course, with the cytopathologist. The pulmonologist assessed whether he could assess sample adequacy appropriately, and it was shown in the study that there was a significant concordance between the pulmonologist and the cytopathologist, who was a gold standard. The problem with the pulmonologist is that the pulmonologist tends to have more false positive results because we tend to assess bronchial cells as malignant, whereas the cytopathologist's eyes are more experienced. Nevertheless, diagnostic accuracy was quite high. And do we have a curriculum proposed? Yes, there is a curriculum proposed. There's a phase 1 of training of a pulmonologist in 150 archive cases of EBUS TBNA, and a cytopathologist sitting next to him and guides him. In the second phase, the pulmonologist does 50 archive cases without the cytopathologist, and the third phase is in the bronchoscopy suite for 200 live cases. When we do this curriculum, it seems that the pulmonologist can assess with a good agreement whether there is a reactive lymph node, malignancy, or granuloma. So a pulmonologist can train to do ROSE quite capably. We have presented our experience as a site in this Congress, and it seems that our agreement was quite substantial with the golden standard, the cytopathologist. We reached a kappa of 0.71 in this study, and we managed to avoid a significant number of transbronchial biopsies. We approximately avoided transbronchial biopsy in about 50% of our patients, given, of course, that we had enough histology material. This was not the case in the previous time that we checked our data, and back in 2013 in the second European Congress, where our sample adequacy was 0.56, which was moderate. So we are still learning. Is there a benefit if we do ROSE in the era of lung cancer genotyping? In this study, it was shown that if we implement ROSE in our practice, we can have 90% of success for EGFR, KRAS, and ALK testing, compared to 80% in the EBUS TBNA control arm. So 1 in 10 patients can benefit from us doing ROSE as regards molecular genotyping. This is a nice publication about an automatic visual inspection method, which is based on artificial intelligence. So artificial intelligence is a mathematical algorithm, is a way of solving problems. And one of the problems is sample adequacy. So you see the sample here on the picture on the left, and how we can get the machine to understand this picture. We can make it into dots and tell the machine which dots are considered a sufficient sample. So when we use machine learning, we can transform our samples to coding, and this has already been implicated in this IRA matrix system, which is an artificial intelligence system which aims to assess EBUS TBNA sample adequacy. So this is commercially available. I have the site for you to look, and I think you will hear more about this in the following presentations. And I would like to thank you for your attention.
Thank you. Thank you, Philippe, also for being perfectly on time. You're ready for a pathology residency by now?
Not yet. We are still learning, still learning.
We'll do a short discussion at the end of the session, if you agree, so we make sure that everybody can talk. So I would invite